next paper is on color visco assisted ILM flap placement technique for large macular hole. Dr. Atul Dhawan.
What happened to this? The one cancelled. Not permitted.
Good morning, everyone. My topic is color visco assisted ILM flap placement, that is CAP, in large macular holes. So for the large macular holes, so many options are there, like retinal autograft, amniotic membrane graft, retinal expansion by the subretinal injection of the saline, retinal massage. But the most common thing which we are using from the last 10-12 years is inverted ILM flap, which was shown by Dr. Zofia Michelwaska. She has given the first paper in 2010, that was conventional ILM flap. Then in 2015, the temporal ILM flap. But always there was anxiety because three questions were there in front of us: how to make a good flap, how much big flap, and how to keep the flap over the hole till the end of the fluid air exchange. So because I am from Chennai, I have learned this how to make a good flap technique from Sarvana Dosa shop. The answer of the second question is how much big flap. So if we'll go by physics, to separate the two glass plates which are separated by one thin film of water, we have to apply some force. That force is directly proportional to the area of contact. So if the area of contact is large, the chances of flap removal during the surgery is very less, and in the post-op period also. Because of this, I have taken large flap. The third one, to keep the flap over the hole till the end of surgery, we need a temporary tamponade. For that, I have taken the viscoelastic, which I have colored with the help of brilliant blue. This is a small technique, CAP. How to color the blue viscoelastic? I have used the 2% HPMC. I have colored it with the help of one drop of brilliant blue. You can see, just shake it and color it. Now this is a large macular hole, and I have used 180 degree of the flap, this is 550 micron minimal hole diameter, and the pre-op vision was 660. Patient was glaucomatous. The vision was deteriorating. That's why I have gone for the surgery in this case. I have used finish loop to make a flap. The best quality of the finish loop is you can control the tensile strength of the finish loop by decreasing or increasing the size of the finish loop inside the eye. So first is 180 degree finish loop. Now I am making the flap with the help of the ILM peeling forceps. You can see there is an angle between the retina and the forceps, and by this I can see directly the ILM, and there will be no injury of the retinal nerve fiber layer. After this, I'll put the flap over the macular hole, and in this bare area, I'll put the temporary color viscoelastic, tilt the eye towards the disc, and take out the viscoelastic at the end of the surgery. This was a U-shaped macular hole. So the result of my surgery was, we have taken 30 patients, 67% female, 33% male in my study. The mean age of patient was 67 years in the female and 73 years in the male. 15 case of the left eye, 15 was the right eye. Best corrected visual acuity, I have taken pre-op, 1, 3 and 6 month post-op. You can see 30 patient pre-op and 29 patient in the post-op, because in one patient I have to do one re-surgery before first month. So I have excluded from the study. The vision was increasing gradually. Now the foveal morphology, re-establishment of the external limiting membrane at the day 7, 1 month, 3 months and 6 months. You can see from no medium to, it has gone to partial and complete at the end of the 6th month of the surgery. The same thing we have seen for the ellipsoid zone, 7 days, 1 month, 3 months and 6 months. From no and partial, it has gone to partial and the complete. Now we have compared this with the visual outcome. In the case of ELM, a significant association was noted when comparing the ELM formation with the visual outcome. You can see here the visual outcome was much better when the complete ELM was there, and it was less when the ELM was less. The same was there in the ellipsoid zone. Now we have compared the group 1, group 2, group 3, which is fully formed, partially formed and no formed ELM and EZ, and we have found these results. Fully formed, the hole was small, and partially formed, it was large. We have found visual outcome. The 26 cases were the U-shaped closure, and the 6 cases were the V-shaped closure. The visual outcome was much better in the U-shaped closure than the V-shaped closure. It is shown here, 23 cases U-shaped, 6 cases V-shaped. Minimal hole diameter, if the minimal hole diameter was less, then U-shaped closure was there. If it was more, then the V-shaped closure was there. Final visual acuity less than, if the CMT was less than 200, the final visual acuity was less, and if it is more, it was better visual acuity. The conclusion is color visco assisted tamponade for temporary purpose is much safer and better than the normal, and U-shaped closure favors the better visual outcome. Thank you.